I am, as usual, going to have things recorded on Zoom. So that way you can access presentations after you hear them for today. That way, if you've missed something or you'd like to have more details about something in the presentation, you can view it there. All right. So welcome. We are getting started this week on our first round of student presentations and you all sharing the work that you've put together in regards to health disparities. So we'll hear from our 7 presenters in just a minute, and I have all the slides and information pulled up for every one of our folks going today. Thank you all for making it here. If you are not scheduled to present today, you're still going to receive attendance, and I ask that you take notes on some of the things that you noticed from the presentations. I'll be talking about this week's quiz, which is a little bit different in its structure, but it will involve paying attention to some of the things that you noticed from this week's presentation. We spent some time last week preparing for this. We also spent some time talking about how we use health and science communication to engage with the public. Including how we use mass media and also how we convey through things like museums, monuments, and other pieces of communication, science and health related issues. So for today, we have 7 presenters, and we'll be going in order from Angelin, Macy, Justice, Garrett, Patrick, Crew, and Kane. And before we do, I just want to give a couple pieces of information about how this is going to work. So each speaker has 6 to 8 minutes. I will use time signals to let you know how you're doing, right? Remember that you, if you're in that 6 to 8 minute range, you're just fine. So if you see that there's 2 minutes left, you're in that good window. And so don't worry about filling both of those minutes. I will give you 4. This is when you've used 4 minutes and have 4 minutes remaining. 3, 2, and 1. And then I'll raise a fist when you're at time, in which case I'll ask you to finish up the idea or thought that you're working on. You are welcome to use slides and online material. Again, I have the slides for all the presentations today pulled up. Please make sure that your phones are silent or off, and please wait for the presentation to end before you step out if you need to use the restroom or something similar. So just as a matter of being respectful to other folks presenting. So for this week's quiz, what I'm asking you to do is to pick 3 other presentations, and I'll be asking you to just make some notes here about what you noticed from the presentations and just your overall thoughts and reflection. So you could either choose to just have your presentations that you choose to write about on the day that you're not presenting, or you could be ambitious and choose to do other ones on the day that you are presenting as well. But I did want to show you a preview for that quiz so that you know what to take notes on and what you might need to work on as you're preparing for that quiz. So to give you a sense of what to expect here, I'm asking you, again, either through the recording or through your notes from the class, to pick 3 of the presentations other than your own. And then for each of those to pick the health disparity that person selected and what communication strategies they recommended. So first, figure out what it is that they addressed in their presentation. Second of all, do you believe that the proposed communication strategies be effective? Why or why not? And then lastly, what did you learn through that presentation, right? So if you're a member of the audience, you might use this time today to take notes on some of the presentations that you have noticed and use that information to help you in preparing for and completing this week's quiz assignment. Again, I'll have the recordings up later so that you can refer back to the presentations afterwards and think back on some of the things that you learned through this process. So that's available there. Kind of using that and going off of that, does anybody have any questions related to the class, related to the presentations or presentation schedule at this stage? Doesn't look like we have any questions at this point. I have downloaded all of the slides for this week. So This is yours, right, Angela? Great. Just making sure. Angela, we'll have you start us off, and you're welcome when you're presenting. You can use the keyboard. There's arrows here, and there is, this is the left click as you're working through material. You can also, if you have videos or other material to work through, pull all of that stuff up as well. So I'll just be here in the audience as you're working through your presentation. So
is this camera facing me? Sorry. Is it? Can I turn it
you
away?
can, if you would like to turn your camera a different direction, you
Okay. Sorry. Okay.
can do so. Right.
So my presentation focuses on low health literacy and the impact it has on Asian American and Pacific Islanders. I'm also focusing on limited English proficiency and how that affects AAPI populations when it comes to healthcare and accessing health information. So what is health literacy? Health literacy is the degree to which people have the capacity to obtain, process, and understand basic health information. Health literacy is also a key social determinant of health and a predictor in determining health status. According to the National Assessment of Adult Literacy, 63 million Americans have basic health literacy, while 30 million fall below basic health literacy levels. So what does it mean to be health literate? To be health literate, people must understand the language in which information is being conveyed to them. They must also have reliable and relevant information, the social skills to discuss health matters with others, and be willing to put the information to use. They should also have interest in the health-related information and be able to, and have adequate hearing and vision to get the information that they need and be able to know how to apply the health information being presented to them. So AAPI populations, AAPI stands for Asian American and Pacific Islander, and they are also one of the fastest growing ethnic groups in the US. So this chart here just like shows a brief overview of like the AAPI community and like the other disparities that they're facing. So in the top left corner, it shows some health, sorry, I can't see, some information about AAPI populations regarding health. So it says that nearly half of 1 million people with chronic Hep B virus infection are AAPI. And then in the second box to the right, it discusses economic disparities that AAPI populations are facing, and in the bottom left, it shows language disparities, and in the bottom right, it discusses educational disparities. So what are the factors associated with low health literacy? So low health literacy, it was found that higher odds of low health literacy are among those who are living in poverty, not being a college graduate, having limited English proficiency, and being foreign born. So this chart shows limited English proficiency was those who have limited English proficiency were most likely to have low health status. So, wait, sorry, I'm gonna. So in here, it shows that self-reported poor health, when compared to those who were proficient in English and not, they received more poor health. They reported poor health. And also people with higher amount of low health literacy had limited English proficiency compared to those who had a higher health literacy. So how does health literacy impact AAPI populations? Low health literacy patients experience difficulties in understanding medical information as well as instructions provided by physicians. It also creates a barrier to positive health. So what is limited English proficiency? Those who are limited English proficient are individuals who do not speak English as a primary language. They have a limited ability to read, speak, or write and understand English. So from the chart, we see that Asians and Pacific Islanders consist of 21% of the LEP population and speak over 80 different languages and dialects. So how does LEP impact AAPI populations? So those who have limited English proficiency experience difficulties with understanding information. And since they're unable to understand the information, they are unable to utilize health records to make informed health decisions. So in this chart, we see the challenges that those with limited English proficiency face. And on the left, it shows how those with English limited proficiency experience more problems with understanding medical situations. And they're also more confused about how to use medications, and they have trouble understanding labels on medications. And since they have trouble understanding these medications and how to properly use them, they have more problems due to the misunderstanding of instructions that they have received. So how can health literacy be improved? Health literacy can be improved through interventions that include communication skills, self-management techniques, as well as teaching patients how to access information. So tailoring interventions to minorities, such as having classes to teach participants how to access health information on the internet may increase self-efficacy, oh my gosh, I can't speak, and health information seeking and health information comprehension. And this will improve their ability to find, evaluate, and use online health information. And by improving communication skills, they're able to build self-management techniques, which increases patient satisfaction and improve chronic disease management for older adults. And then this table here just shows some of the things that limited English proficiency Asian Americans would like to see in their healthcare provider. So then presented is the various quality domains and needs that Asian American patients want / look for in a healthcare provider. And as you can see, some of these needs are not met. And by being able to meet these needs will help overall improve health literacy among AAPI populations with limited English proficiency. So it can also be improved by adding linguistically and culturally tailored health information, which can lead to improving overall health quality. And adding culturally competent health literacy materials also leads to improvement in healthcare utilization, adherence, and management. So some steps to help with LEP. One is having high quality interpreter services. So by having interpreters on site or being able to access them like via video can help with the communication process. Create a culture of equity and promote good communication skills. And basically, having critical health information available in multiple languages can increase patient understanding and make patients feel comfortable. Having language concordance improves patient satisfaction, engagement, perceived understanding, utilization of preventative services and outcomes, and being able to communicate with patients and respect their cultural beliefs and understand that they may have some difficulties when it comes to language and understanding. Oh my goodness, sorry.
All right, Angela, thank you so much for getting us started in thinking about health disparities and ways to promote health equity and communication. I really like the way that you incorporated supporting material and visual aids here and talking about Asian American and Pacific Islander communities and health disparities. In fact, I really like your use of supporting evidence such as the White House diagrams and also your visual aid toward the end talking about how Asian American and Pacific Islander communities rank and address some changes in the healthcare system. So I thought that the identification of those specific strategies and really drawing from the expertise and background that you developed through your research on this project really worked well here and did a great job of getting us started in thinking through this material. So we will move on and continue to develop these ideas through disparities and hearing from Macy. So again, you're welcome to use either the keyboard there, click, move it around, or whatever you like.
Thank you. Okay. So this is my presentation on Black maternal mortality rates in the United States. Okay, so just the basics, the mortality rate is essentially like the ratio of deaths within a specific population compared to the total amount of individuals that are being observed. So for example, just with COVID, it would be like the number of deaths per 100,000 people in the US. And it's often related to a specific time frame as well. So it would be like from 2020 to 2021. It could be like the number of heart attacks that led to death from 2010 to 2020, but they're always associated with a specific time frame and associated with a specific cause. And it's used so that public health officials and doctors can kind of keep track of what diseases are afflicting populations the most. Okay, so maternal mortality rates in the US, in 2020, there were 861 maternal deaths, and that's quite a bit higher than it normally is, which is around 700. A maternal death is essentially a death that occurs during pregnancy, during birth, or up to a year after birth due to pregnancy-related complications. So it wouldn't count if like a pregnant woman got into an accident and passed away due to that. It also includes deaths up to, I believe, 30 days after a miscarriage or an abortion. It could also include things like ectopic pregnancies or preeclampsia, so pretty much anything in that scope. And then these rates always increase with age. So at the age of 40 and up, risks with maternity almost double. And 2 out of 3 of these deaths are always preventable. Okay, so there's many racial disparities in maternal mortality rates. So for non-Hispanic Black women, there's 55.3 deaths for every 100,000 live births. And that's 3 times the mortality rate of non-Hispanic white women, which is quite a lot. And it's also higher than that of Hispanic women and other BIPOC people. So Alaska Natives, American Indian individuals, AAPI. And then there are many causes, and some of them include variation in the quality of healthcare that they're able to receive, chronic conditions that might affect certain races more than others, and then social determinants of health, which include like financial status, the housing situation you're in, the healthcare you can receive, your environment, things like that. And so from 2004 to 2014, communication failures were the second leading factor in maternal mortality and morbidity rates across the board. Some of these things include the racially insensitive, sometimes biomedical approach, just because it's very much focused on Western medicine and that approach. Doctors also have been known to dismiss pain due to people's races. They expect them, or they have this mindset that if you're of a different race or a person of color, you have a stronger pain tolerance. And this is especially prevalent when seen with doctors interacting with Black patients. They also can view Black patients as a charity case, and so they don't take them seriously when they have concerns because they don't believe they know their bodies. And then structural racism within the health systems and implicit bias within doctors. Okay, so this is just a quick graphic. On the far left is total maternal mortality rates by race and Hispanic origin, and then these are Black individuals, and you can see it's way higher than all the other ones. This is the maternal mortality rates, but by age. And as you can see, 40 and over is much higher. And these racial disparities remain pretty similar over age and education differences. So you can imagine that number is a lot higher. And then this is from 2018, and then comparing, you can see that American Indian and Alaska Native women still have, they have higher mortality rates, but not as high as Black women. And so one thing that the CDC is doing is they have this thing called the Hear Her campaign. Essentially, it's trying to spread awareness about issues that can occur while someone is pregnant and during birth, and it's urging a social system, so like families, friends, and then doctors and healthcare individuals to essentially pay attention to the women around them and listen when they have concerns, because they're the ones that know their bodies. And if something doesn't feel right, that's why they're talking to you. It's not because they're crazy or anything else. So there are many ways that health information can be communicated that can solve this problem. So providers can ask patients questions for understanding. They can try and help them to, and their support systems to understand risks more. They can recognize their own bias and work to shift that. They will make sure to address any and all patient concerns instead of brushing them off and telling them, hey, I'm the doctor, I know better than you, so I don't want to hear it, and then provide respectful care. So some things that they can do are communicate in culturally and appropriate and sensitive ways. And this can be learned through participating in cultural competence, awareness, and training, which, as far as I know, is not standard in medical school, but is something that would help this problem a lot. And then using the patient-centered approach, because it puts a little bit more focus on patient autonomy and gives them like a space to advocate for themselves while still feeling safe. And then the US Department of Health and Human Services has this thing called class training. And it essentially, it's a free training that any medical provider can take. And it helps to improve care of patients by learning about their experiences, values, and beliefs. It works on the provider's self-awareness and helps them to learn how to address different cultural identities and how to learn about them. So it essentially teaches them sensitive communication tactics and all of that. But the biggest thing that can be, I guess, worked on is through listening. So if the doctors just listen more, which is what all of this kind of focuses on, it'll help them to understand their patients more and perhaps identify risks before it leads to morbidity or death. Thank you.
Awesome work, Macy. I really appreciated the way that you kind of showed examples here through the Hear Her campaign, through identifying, including this excellent citation, the Adayaya or Adasoya site. I'm trying to remember where it was there.
Oh, it might be.
Oh, Atabaya, yeah. So that site was a great example here of how some of the issues of implicit bias, of expectations about intolerance and other kind of racially biased assumptions, right, can impact and cause these kind of health disparities. So I really like the clear communication, including suggesting cultural competence training and similar measures to address these issues, right? There was a lot that I kind of learned through your research and sharing here too, and I thought you did a great job of identifying these challenges, problems, framing the topic in a super understandable way too. So really great job with these first two presentations and getting us started and continuing to think about disparities in health and the way that health is communicated. So our third presenter of the day is Justice. So I have your presentation here, and I will. Is that this one, right? Oh, sorry. There we go. Okay. Yeah, you can use the arrow, or you can just.
Hi, this is my presentation on childhood obesity. So in the 1980s, the National Health Guidelines were implemented to emphasize including many grains and reducing meats and saturated fats in our diet. Since then, obesity has rapidly become a shocking issue in the US, and now it even affects our children. In 2022, 1/3 of our children have become overweight or obese, and in low-income areas, this number rises to 50%. Along with obesity comes a host of chronic diseases that impact lifespan and quality of life. 1/3 of people born after the year 2000 are expected to develop diabetes, which comes along with a myriad of terrible results, such as loss of vision, limb amputation, and kidney failure. Additionally, many kids are now being diagnosed with diseases previously only seen in adults, such as hypertension, sleep apnea, heart disease, and cancer. 1/3 of obese children are diagnosed with fatty liver disease. 20% of those children will die within 10 years of their diagnosis without a transplant. Overall, the obesity rate of children has risen by 300% in the last 30 years. In addition to the medical ramifications, there are many social and lifestyle effects as well. Obese children often suffer from psychological issues such as depression, social anxiety, and low self-esteem. They're also often bullied and unjustly blamed for their condition. These children are caught in the middle of a system of food technology designed to make things hyper-palatable and addictive, influential advertisers that market directly to children, and highly cheap and processed food being simply what is available. Obese children may struggle with doing many day-to-day activities. They're unable to run and play like other children. Many of them also suffer academically and in other forms of achievement. Obesity for children most often becomes a lifelong struggle. 80% of children who are obese at age 10 become obese adults and will have to manage chronic disease for their entire lifetime. Obese children may have to make frequent medical appointments and may have to take medication, many of which have detrimental side effects. There are many reasons for this sudden epidemic. Kids today are pacified by and become addicted to the use of electronic devices instead of being active. Diets, of course, have become increasingly unhealthy, and it's not just what is being eaten, but how. Frequent snacking has been normalized, so there is often very little downtime between consumption. This is a problem because hormonal response keeps frequent eaters in storage mode and unable to access stored fat for energy. COVID-19 has exacerbated the problem dramatically. According to the CDC, children who were already overweight gained over twice as much weight over the course of the pandemic as normal weight children. As I alluded to earlier, children are estimated to be exposed to 10,000 advertisements per year, a majority of them being for soda, sugared cereal, and fast food. This inevitably leads to these foods landing in a family grocery cart. There are also many overlooked factors that come to light with more recent research. Many circumstantial factors affect a child's microbiome in ways that lead to obesity, such as C-section birth, bottle feeding, and antibiotic use in infancy. Mom's stress levels during pregnancy and a stressful childhood home environment increases cortisol, which affects insulin levels. These factors are often poorly understood by the general public and may lead parents to not understand the ramifications of some of their decisions in pregnancy and early childhood. Unfortunately, the most common solution that is proposed to combat this issue has been ineffective. There exists a common mantra of eat less and move more that does not take into account managing hormones and weight maintenance, nor does it get to the root of the issue. Just eating less junk food while mainly subsisting on a diet of junk food is no solution. Access to highly processed food should be severely limited, and snacking should be eliminated entirely. Soda and juice are another key culprit, as they contain a large amount of calories and are responsible for insulin spikes. Sugar and soda consumption is 5 times higher than it was in 1970. Recently, scientists have proposed the protein leverage hypothesis, which may explain some binge eating patterns. This idea suggests that humans are driven to consume foods until we meet our minimum protein or amino acid needs. This is why you can eat an entire bag of chips and still not feel satisfied because there's no protein there. When combating the obesity epidemic, the emphasis has been placed on changing patterns of fat and carbohydrate consumption while the role of protein has been largely ignored. When engaging with people on this subject, it's really important to approach them with empathy and understanding. As expressed earlier, obesity, especially in children, is not the victim's fault. Regardless, this is a really important issue to confront, not to shy away from or attempt to normalize. It may seem kind to try to protect their feelings, but you're helping no one by ignoring a serious health crisis. Part of school is creating a safe environment should extend to food choices. Additionally, they should be teaching kids how to cook healthy meals and make healthy choices as part of their curriculum. Many schools have made cutbacks to recess and PE classes to the detriment of their students' health. Medical professionals have not been successful in their approach to this issue, the idea of move more and eat less that I mentioned earlier. They need to change their approach to integrating the family and to working together, helping kids and making small, achievable goals, and educating them about the importance of mitigating this issue. The subject of government regulation is a bit beyond the scope of this presentation, but nutrition guidelines are not in line with quality research. The diet the government recommends affects millions of people and is unfortunately up to us to hold them accountable to update their standards. Just as advertising is used with great effect to promote obesity, I think it could be used with great effect to mitigate it. There could be government sponsors, PSAs that promote healthy diet and activity. Organizations such as neighborhoods associations could be encouraged to clean up and help make safe places to play within cities. Parents of at-risk children often believe that obesity is something their child will grow out of, but as we looked at earlier, this is far from reality. Parents already often attend classes to prepare for childbirth. These classes could be expanded to informing them of things such as factors that affect their child's microbiome and how to craft a healthy diet for their early years. Finally, in many kids, obesity has been such a problem allowed to persist to where intensive individualized approach is necessary, such as counselors or weight loss camps. These people should be well trained in nutrition and well versed in communication skills. Many obese children have accepted their fate of being obese forever. I think the most important thing we can communicate to them is that it's absolutely possible to make their way out.
So Justice, thank you so much for getting us thinking here about childhood obesity. I have to say it was interesting hearing your presentation from this angle. I could see the soda vending machine from here, which is an interesting offset for what you had to share. I really appreciated your work here in helping us to think about childhood obesity. I think you do a great job of not only explaining some of the challenges here, but also some of the ways in which the existing communication strategies and efforts have been unsuccessful. I really liked your points here about how the normal ways we communicate about childhood obesity, like you need to get out more and eat less, just don't work, right? And so oftentimes you'll hear these repetitive campaigns that don't necessarily get at some of the causes or methods to better support those health issues. So I thought you did a good job here of getting us and thinking about how to kind of course correct toward more effective communication and outlining some good strategies that help us to get there. So thank you so much for getting us thinking about some of these topics and helping us to understand this a little bit better. So our fourth presenter of the day is Garrett. Got your presentation up and ready to go. You're welcome to either click or use the arrows as you're working through.
Alrighty, so as the title suggests, we'll be covering some communication and economic disparities of impoverished and low-income diabetics in the United States. We'll be going over some foundational and foundational data as related to socioeconomic issues, moving into some of the communication informational issues, covering the main issue of these things exacerbating existing medical issues, as well as potential communication fixes. So just some foundational data to give you a sense of the potential overlap here. This comes from the US Census Bureau and the Center for Disease Control and Prevention. The poverty rate in the United States has actually minorly, but been steadily increasing since the mid-2000s. Compared to 2019, it's gone up a fair bit, upwards of 3.3 million impoverished persons in the United States compared to 2019. And the Center for Disease Control has actually noticed quite a few diabetic persons in the United States, both diagnosed and undiagnosed. The actual number of low-income diabetics in the United States is unknown, but the potential overlap is quite extreme. To give you a better picture of what's going on for specific low-income diabetics, this comes from another CDC study. The socioeconomic disparity of low-income diabetics in the United States compared to the late 90s and early 2000s, compared to the mid-2000s, has actually increased quite a bit, upwards of 40% overall among the diabetic population, and specifically a fairly sharp increase in the past 15 years, or in the 15-year gap. Looking at the actual individual economic impacts, this comes from the American Heart Association, looking at a 2013 to 2017 study, roughly 9,000 interviewees, which they say is representative of upwards, I believe, of 13 million Americans theoretically. Of these interviewees, 41.1% of them said they came from financially insecure families, and 15.6% said they were directly unable to pay for medical bills. Another major issue that came up was a lot of the stresses involved in being unable to cover medical costs due to diabetic costs and concerns as well. And there was generally a huge push for better communication strategies among physicians to patients as a result of these issues. Now, I should clarify, there wasn't actually that many specific communication disparities related to low-income diabetics in the United States, but the few that are present do present some potentially concerning trends. This one looked at the rate at which, I believe it was racially diverse diabetics coming from low-income positions would disclose to their doctors if they were on alternative care. Now, alternative care usually refer to things like herbal medications. In this study, none of these alternative medications were either that costly or provided a serious health risk to the person involved. But of these, roughly 25% of the people stated they did not actually disclose to the doctor that they were on alternative care. The reasons why are actually fairly similar to what we've looked at in the text thus far. Some of them simply did not disclose it because the doctor didn't show interest, therefore they didn't think it was important. Others simply thought it wasn't the doctor's business to know. Again, the costs of these actual alternative treatments were relatively low, and none of them were that concerning, but it did raise the issue that if patients are not disclosing to their doctor, it's going to cause further issues of potentially more costly or even damaging alternative medications not being brought up, doctors being unable to do this, and just generally causing some trust issues and breakdowns in communication further down the line when the situations become more serious. So a lot of other communication disparities that came up in multiple sources was the potential limited access to technology of low-income diabetics with things like apps and whatnot. Of course, this is becoming less of an issue due to the more accessibility of consumer technology, but it did come up. The need to know basis culture that we've again seen in the text quite often, of patients not communicating to doctors because they think the doctors are uninterested, and doctors keeping patients in the dark because they think they won't understand. And one thing that we'll get to in a minute is the effectively lack of a self-care plan discussed between patients and providers. Patients are effectively left with whatever doctors will give them and have little to no inclination to manage the conditions themselves. So the main issue, again, comes from a culmination of a lot of factors rather than a singular or a handful of major pressing problems. Due to the limited resources that a lot of low-income diabetics have at their disposal when it comes to things like surgeries, doctor visits, interventions, and especially insulin, a massive emphasis is put on perpetual treatment and self-management. But because they haven't actually discussed these things with their doctors, they have little to no experience in how to actually properly self-manage, whether it's taking medication, doing tests, or even simply how often they should come in for follow-up visits. These effectively exacerbate existing medical concerns where low-income diabetics could be left effectively to handle these conditions entirely on their own and could even be put in life-threatening conditions if they don't understand the seriousness of the condition. Now, as far as what could be done, there are quite a few general solutions. Some of these came from the Journal of Family Practice. These are mostly things we've seen before, just generally making a more open communication culture between patients and providers. Patients need to bring concerns to their doctors. Doctors need to inquire more about patient concerns, let them know what's going on, how they can do. One thing that was actually proposed by the Journal of Family Practice was the ask, listen, emphasize approach. Again, digging into patient concerns, asking what their concerns are, letting them know what's going on, and so forth. Other multi-source concerns that came up were just, again, getting back to this two-way disclosure, back and forth, constant communication, and especially talking about potential treatment options as it's related to cost and what the patients can do themselves to manage their condition. Now, this was actually one of the most promising things I found. This was admittedly a slightly dated study. I believe it was from 2001, so not all of the data still applies. But this was done by a group that authored the book Medical Care. This was roughly 250 patients, low-income diabetics, of course, from 2 county healthcare clinics. And in addition to their regular consultations with doctors, they had biweekly automated telephone disease management calls. These were 5 to 8 minute recorded calls on an automated system where the patients were reminded of what was going on with their condition, reminded of the things they needed to be doing to self-care, such as insulin checks, and also had the ability to pass on any concerns and questions they had at the time. If enough questions or enough concerns came up, the patients would have a semi-frequent call with a diabetic nurse educator who would directly address their concerns, pass on any information to their healthcare provider, and so forth. This was actually very successful, with patients noting quite a bit of an increase in how attentive they were to their own self-care practices. 86% of the patients in the study recommended that this be adopted by other clinics in their area, and 81% said they were actually very satisfied with the information they received from the nurses. So just wrapping this up, again, like I said, the overlap between potentially low-income persons and diabetic persons is fairly significant in the US and is seemingly growing each year. The potential risks involved with perpetual treatment, again, are exacerbated by these low communication environments and the general lack of information provided to patients, exacerbated, of course, by the limited resources available for patients to actually seek emergency intervention if required. The general solutions are obviously just better communication environment between patients and practitioners. Again, things we've seen so far, things that are probably coming up in everyone's issues looked at, and just generally fostering a very clear self-medicating, self-treatment system for patients. And here's the big for that.
Thank you so much, Garrett. This is a topic and issue that I really going in did not know a whole lot about, but I think is an incredibly important one. I really appreciated the way that we integrated a lot of the elements from the text and things that we've discussed in the class so far related to health disparities, and particularly how a lot of patient-provider communication that doesn't go well really discourages participation, right? That oftentimes, if we feel like our conversation with our doctor is dismissive or topics just don't come up, we're really seeing the sort of longer term consequences and people feeling deterred from attending and dealing with those visits in the future. So really good work here in terms of linking material from the course, identifying into really clear kind of roadmaps and outlining of your main points, the steps that we can take to address this issue and ways that we can identify the specific kind of income disparities that relate to access to diabetic diagnoses as well as care and support. So thank you so much for getting us engaged and thinking on this topic. We have 3 more presentations scheduled for today. So we'll be hearing from Patrick next, who is here to talk about people with disabilities. So Patrick, you are welcome to use the keyboard there, click or move the arrows. And whenever you're ready.
All right. So the group that I chose for this presentation are people with disabilities, and I'm basically just going to focus on 2 specific aspects. So children with disabilities in school, and then people with disabilities in the workplace. So a little bit of background information. 61 million adults live with disabilities in America. Of these people, 13.7% have mobility disabilities, 10.8% have cognition disabilities, 6.8% have independent living disabilities, 5.9% with hearing disabilities, 4.6% with vision disabilities, and 3.7% with self-care. And as you can see, like a lot of these are going to cause a lot of problems, as they transition into adults, especially with the independent living, because most children with disabilities that are in like group homes, they don't have that preparation to move into their adult life. So it makes, independent living, which I mean, it's just doing errands and, just the everyday life is almost a impossibility for them. So 1 in 3 Americans with disabilities do not have a usual healthcare provider, and this can lead to them being more susceptible to heart disease, obesity, lung failure, and more. So 1 in 5 children in the US have a learning disability. The most common are ADHD, dyslexia, dyscalculia, dysgraphia, and processing deficits. So the dyscalculia is basically trouble with interpreting like math, so like addition, subtraction, things like that. Dysgraphia is writing disabilities. So the dropout rate is 11.6% higher than kids without disabilities. And this is, I mean, there's a lot of reasons to it. Mainly, the biggest reason is that there's a poor teacher communication. So 70% of students with disabilities spend 80% of the time in classrooms designed for the general population. There's a lot of schools that have, special education classes that are specified for people with disabilities, so they can be taught, at a slower pace, and they can get a more general knowledge of whatever the topic is that they're learning. But I've seen in a lot of rural areas, especially smaller schools. I know for my school, we were like barely 1A, and we didn't have any kind of accommodation for people with disabilities. There was no classroom. They all spent their time in the general population classes, and I've seen, there were students in my class with autism and a few other things, and it was a constant struggle because they didn't have any accommodation for it. So another problem is improper implementation of IEPs. IEPs are individual education plans, and all teachers have to create them, but they're not required to implement them. And this can lead to a lot of issues for people with disabilities to learn at the right pace for them. Another problem is student bias. So there's a major problem with students without disabilities that discriminate people with, or students with disabilities, especially in sports. You see a lot, growing up, the best way to make friends is like being part of a sports group and playing on the playground, playing at recess. But there's no accommodation for people with disabilities, and that can create a huge schism. And then there's also a poor transition from high school to college. Throughout school, people with disabilities, they'll have these IEPs and these special plans for them to learn at the right pace for them. But then when they get to college, it's all gone. They're on their own basically. And there are resources that they can go to, which I'll get to later, but there's a terrible transition for them to go to like higher education. So this is just another statistic I found. People on the autism spectrum are more susceptible to bullying. So 63% have been bullied. And the solutions for this would be to have better IEP implementations and individual teacher training. Higher education schools should promote the disability resource offices more. And actually 70% of students with mental health disabilities are not registered for accommodation. And I also think that if you bring more speakers to high schools, it can help raise the awareness of the bias and harassment that people with disabilities may face. And it'll also make students more comfortable with communicating to people with disabilities. So this was an article I found, and basically it was an observational study conducted by researchers in one large urban school district. So all teachers are required to teach Common Core state standards, which is just the guideline that teachers have to follow to teach a specific criteria to their students. And so they used a focus group of special educators to perceive and analyze the teachers' effectiveness of teaching these standards to the students with disabilities in the general education classes. And results showed that there's a huge lack of information, research, and teacher training on the effectiveness of teaching these standards to students with disabilities. So a lot of teachers that are going in the program before, they have their own class. They have lessons on teaching students with disabilities, but they don't have the actual in-person training that they have to go through. And I mean, it's obvious that it really hinders their effectiveness on teaching them. So in the workplace, people with disabilities experience discrimination and bias. There's a lack of jobs and job modification. There isn't any good communication comfortability for employees and managers, and there's a lack of safe zone for people with disabilities. So the solutions to this would be to train managers on disabilities so it makes managers more comfortable, and also it can help provide more job modifications to accommodate people with disabilities. So when I say job modifications, I mean like specific things that would tend to the people with disabilities. Like, for example, I don't know, if there's a blind person that works in a grocery store, they're not going to see a bulletin board with Braille on it to know like specific instructions. So I mean, it's going to hinder their ability to work. You should also provide a safe zone in the workplace for people with disabilities. So people with disabilities become really overstimulated when work becomes, too fast of a pace for them. And so it would just provide them with a place to relax and gain control and get back to work. Then also train appropriate staff as mental health first aiders, and then require staff to take a course on working with people who have disabilities. So the last article I found was an experimental study that used imagined contact as a strategy to reduce bias and discrimination in the workplace. Imagined contact is just the use of positive words and goal setting between group members, and results showed the effectiveness in reducing bias and promotion of equality for people with disabilities in the workplace. So just to conclude this presentation, I think at all levels, people just need to have a better communication competence for people with disabilities because they are set at an unfair advantage and they don't get the support they deserve. So it'd just be best for everyone to, just educate themselves on how to properly communicate with people with disabilities.
Thank you, Patrick, for giving us, I think a really important look into the unique array of experiences and challenges impacting folks with disabilities. I really like that you were applying this both to look at schools, including harassment and bullying, and challenges with education and lack of resources, as well as investigating this kind of in a workplace level. I like the specific strategies you identified, and also some of the challenges of, adequacy of resources and support, sort of identifying both the social and sort of resource-based factors behind some of these disparities. My older sister is a middle school special education teacher and has dealt with a lot of a similar set of challenges in terms of being able to actively implement curriculum that's designed to support students with disabilities from a lot of different backgrounds too. So there was a lot of material there that was certainly relatable, important, and I think adds a lot to how we think about and address some of these challenges. So great work here. Our sixth presenter of the day is Crew. So we'll hear from you next in sharing and talking about your topic. And thank you for continuing our discussion for the day. You're welcome to use the click here or the arrows.
Okay, so hey, so I'm doing health disparities in death and end of life care. So a quick introduction from like patient to family to practitioners, various disparities do exist within the realm of end of life care. So whether it be due to race, age, socioeconomic status, location, and even the type of illness, end of life care can look very different for various different people. So we're going to look into why and how health disparities exist in end of life care and explore ways in which this issue can be fixed through communication. So to identify the problem, the issue here is inadequate end of life care, and the population being impacted are terminal patients without the resources to be in the best facilities. So how should end of care treatment look? Much like how the Hippocratic Oath states do no harm, a more focused philosophy for terminal patients could be alleviate suffering. So end of care should do its best to alleviate physical pain, meet mental and emotional needs, and keep spiritual needs in mind, and also aid in everyday and practical tasks. So alleviating the suffering of the families and proper communication between them, patient, and practitioner is also vital for the end-of-life process. So a group to look at right off the bat is Native Americans. So due to many factors, including geographical location, lack of cultural sensitivity, Native Americans often do not have access to ideal end-of-life care. So low population density and geography often prevent tribal end-of-life programs from being as accommodating as traditional end-of-life hospice care. So furthermore, lack of cultural sensitivity from non-tribal programs often steer terminal tribal patients away. So it's vital for care providers to listen to the needs and belief systems of their patients in culturally relevant ways. And most programs are not capable of doing so, resulting in the disparity. So kind of related to that issue is how the disparities are in rural communities altogether, because they experience kind of some overlap. So the end of care and hospice services in rural communities are often understaffed, lack resources, and are too expensive in regards to the money of those living in the area. As a result, many people in these communities don't use Medicare hospice services and have an increasingly negative quality of life before death. So with traveling to large cities already a major hindrance to terminal patients, the costs of them are also way higher than they can afford, on top of the already overpriced facilities in the rural areas. So another group that I found pretty interesting was there's a disparity with patients with different illnesses as well. So currently the best top levels of end-of-life care are extremely cancer-centric. And despite most people in the US dying of diseases other than cancer, end-of-life care is still disproportionately primarily focused on cancer. So patients with end organ failure and frailty are more likely to die in the ICU, alone or just with doctors, than patients with cancer and dementia who are more likely to die in a hospice care facility where family can be easily presented nearby. And it has been shown that end-of-life care is given in regards to the diagnosis itself, rather than the patient's individual underlying preferences and needs. So they're just going to say, oh, we're going to put them in the cancer facility, despite people with other illnesses, they could just die in the hospital room or ICU. So despite the content of the last slide, other disparities directly relating to this cancer appears within the bounds of race. So a study from 2017 shows that non-white terminal patients in primarily minority serving hospitals are 33% less likely to receive end-of-life care than of those in alternative hospitals. This shows that there's a disparity in the very institutions in which end-of-life care should be done. So as a result, a higher percentage of death of minority groups are reported within the ICU, once again away from family, causing more suffering for both patients and family. So furthermore, undocumented immigrants in the US are at an extreme risk of low quality of life and suffering during terminal illness. 1 in 3 hospice programs will outright refuse to care for these patients, and the ones that do will only offer extremely limited care. Furthermore, with a lack of insurance, even if they can get care, it'll be incredibly costly, and language and cultural barriers are also a hindrance to the quality of care given. So within low income, despite the Affordable Care Act, limitations have been arising in recent years, which limit the quality of end-of-life care. So varying from state, it's different in state, but some Medicaid and Medicare plans won't even cover hospice, and some, if they do, it'll be extremely limited. So some patients may have a quota on prescriptions as well through their plan, which can add to increased suffering towards terminal patients in the end of their life. And nursing home facilities are often underfunded by Medicaid, and all these issues were only worsened by COVID-19, and they're still trying to catch back up. So from another interesting perspective, there's disparities within the healthcare side as well. So end-of-life care and communication has only recently been implemented as a standalone topic in schools and training for junior doctors. And young doctors are often not adequately trained nor emotionally prepared to deal with terminal patients. And they are with their families as well, which can make suffering even worse all around. So it's often the interns who are directly involved with dealing with these patients. And I guess in the hospital world, it's considered like the grunt work to deal with them and talk to their family. And interns and junior doctors alike both show negative emotional responses to working with these patients and receive little to no training, which can further the suffering of everyone involved. So some communication strategies to address this issue, other than a fundamental change in our healthcare system, which will have to happen from a legislative standpoint, changes can still be made. So through effective training of healthcare providers, suffering of patients can be alleviated. By diversifying staff and making providers culturally sensitive, groups who were originally steered away from end-of-life treatment will feel more open-minded to it. And then communicating clearly and early on with the patient will help you understand their needs the most. Keeping families in the loop and taking all spiritual needs and requests from the patient seriously will fundamentally aid in alleviating the suffering of the patient and their loved ones. And end-of-life communication should not be an event, but a process which takes place over weeks or even months. So in conclusion, we're all gonna die. So death is a natural process of life. And by addressing these disparities, we can literally make the lives of those people impacted more fulfilling and meaningful through mindful and empathetic treatment and health communication. Thanks.
A dark but kind of fun note to end on, I suppose. But thank you for that. I actually really enjoyed the way that you shared and talked about some of these disparities in end-of-life care. Again, I think this is something we don't always think about or dedicate a whole lot of attention to in thinking about sort of how factors such as race, socioeconomic status, and so on can impact that process. And I really enjoyed where in your presentation, you also kind of flip this around and discuss these disparities from the perspectives of providers, right? Because oftentimes we might be frustrated or see problems in the healthcare system, but we also want to understand it from that other side, where you were reporting on younger doctors who kind of get put in positions of the emotional complexity and challenges of navigating end-of-life care, and it gets kind of treated as grunt work. Go do this, right? One thing we've talked a lot about is that a lot of younger doctors in working through the healthcare system and building their credentials deal with really significant burnout and challenges related to mental health and navigating that entire process. And so I thought you did a great job here of helping us to see kind of from that perspective how that labor is being distributed and the impact that that can have on young health professionals too. So really good work here in helping us to think about and explore this topic from a lot of different angles and really good level of focus here on this. All right, so our final presentation of the day, certainly not least, is from Kane, who will be talking to us about disparities and issues in health scams. You're welcome to either click or use the arrow to work through.
Okay, awesome.
And whenever you're ready.
All right. So I'll be talking about the disparities and issues of healthcare scams, mostly related to elderly patients. So what do healthcare scams look like? Healthcare scams come in the form of telemarketing calls, text with links on your phone or in apps, emails, social media content, and advertisements on social media. Healthcare scammers will usually, if not always, request payment, usually in advance. Sometimes they'll only request personal information, and that's usually to sell it to other scammers. Who do healthcare scams affect? Healthcare scams affect the elderly, low income, disabled, those without health insurance coverage, obviously, and people in a crisis because they're more vulnerable and less likely to think through the possible risks and what people are offering them. But even though these are the most likely people that healthcare scams will affect, it's important to understand that everybody can be affected by healthcare scams and to always be careful. The disparities of healthcare scams. Elderly people are affected the most by healthcare scams, and it may be because their cognitive function is impaired. They're not able to see the little bits and pieces that healthcare scammers say or do or don't say or do that should come across as sketchy to most people. And there was a small study that suggested that elderly people's ability to detect these sketchy situations is weaker than younger people's ability. Another possibility why this might be the case is that elderly people are socially isolated. Most older people, their children have left the house, or some of them, their spouses may have already passed on, and they don't have people around them to immediately go to consult or communicate with, to ask, hey, is this a healthcare scam? Should I trust this person? Does this sound risky to you? They just don't have a support system available to communicate with to help them out with that. The effects of healthcare scams. Healthcare scams usually result in a significant or even devastating loss of money. Older people often have a lot of money saved up because they've lived a long time and they've just got a lot of savings. They might be retired. And in fact, the majority of the country's wealth is with the ages 57 to 75. And this is probably one of the biggest reasons healthcare scammers target elderly people. And healthcare scams also result in a lot more calls, spamming calls around your entire family. And because every time you answer the phone or you provide any sort of contact information, that personal information is getting sold and put on a list for other scammers to call you and contact you and your family. It's just kind of annoying. These were 2 questions that I was curious about in this class, and you can just raise your hands if you want to. Have healthcare scams affected anybody that you guys know? And this could be just a raise your hand if it's a yes. Do you think there's enough information out there that's easy to access and understand out there about healthcare scams, especially for older generations? Yeah, I agree. I think if there was enough information out there that was easy to access and effectively delivered and efficiently delivered, that there would not be as many victims out there as there are right now. So what our healthcare providers can do to help? It's important for older people to understand how these scams work and the red flags that they need to look out for in order to protect themselves from becoming victims. And our healthcare providers should provide information that's easy to obtain and understand, hand out things like brochures or put up signs around doctors' offices that are easy to read and maybe have bigger words that could catch the eyes, because I know most elderly people aren't walking around doctors' offices looking at every brochure and sign that they see, because they might have aches and pains and just want to sit down. And just having something to catch their eye and to look out for, and that they know that it'll help them protect themselves. And there's also already in some stores, there have been warnings by gift card racks, which is what healthcare scammers usually ask for as payment. Just warnings that, hey, if you're buying 1 billion gift cards for some guy who's calling you, you probably shouldn't do that. Another thing that I saw, I was looking at some news broadcasts, and they said that healthcare providers should encourage their patients to check with their doctor's offices to even see if these health insurances would be accepted by their providers or by the doctor's office. And just overall, we need to help improve the financial health literacy of our elderly patients. Online healthcare, is it safe? As we all know, e-health and m-health and telemedicine can be very safe and very beneficial to older patients, especially older patients, because a lot of them may not want to leave their house for a number of reasons. Maybe they just don't have the capability of leaving their house, or it might be painful or very uncomfortable for them to leave their houses, or they just might be wary of going to doctors. And our healthcare providers should ensure that older patients know how to tell a good mHealth app from a sketchy mHealth app. And even the creators of these apps should be implementing things like credentials that are easy to access and easy to verify the validity of these credentials by researching in ways that older people can just easily do or look up. Avoiding over-accommodating in communication. So when we're talking to older patients about healthcare scams and how they should look out for them, we want to make sure that we're communicating to them respectfully. As we know already, if we talk to older patients without respecting them, or like we're over-accommodating, they might lose a lot of trust in us, they might get angry. And I think trust when we're talking about healthcare fraud is everything that we need to, in order to protect the older generation. And they need to know that it's serious and that they need to do everything they can to protect themselves from becoming a victim. And that would be it.
Thank you so much for wrapping up our presentation for the day, Kane. We talked again a bit about health disparities as it relates to scams and fraud, but I really like the level of focus that you gave on more elderly people in navigating the potential of those scams and talking about some of the physical and developmental ways in which they might be targeted and more susceptible, and also some of the generational differences and technology and the ability to recognize and engage with fraudulent information. I really like the way that you kind of posed some questions to us about how we can make this information more accessible and straightforward, and really provided some great solutions there that I think are important as we're thinking about health scams and some of the disproportionate impacts that those can have. So this is actually great because we ended up having everybody in the class here today. So thank you so much for either presenting today or participating in the audience and hearing the work and efforts that you all have been developing in this class. I'm really impressed with this round of presentations. I thought that you all did a great job of setting a very high bar for all of these and getting us really thinking about a lot of health-related topics, integrating material from the class, and really kind of approaching topics that you were interested in a super meaningful way. So thank you for doing that. And again, thank you for being here to participate and support other folks in the class. If you already have some good notes and points on some of the presentations, are welcome to do this week's quiz and start to enter that information, or if you want to hold off some of yours until tomorrow, or until Wednesday for that round of presentations, you're welcome to wait until then. I did want to let you know before we get out of here that I did work through and grade your annotated bibliographies, so your scores are available on Canvas. I'm also happy to talk one-on-one if you'd like to discuss them more. Some of the things that I noticed, I think people did a great job in terms of including the citation formatting. People did a good job of providing some supporting details about issues in health. One thing to continue to work on as you're thinking ahead about future assignments in the course is just making sure that you're addressing some of the minor convention issues with your annotation choices, and that you're continuing to look not just in terms of health, but also in some of the ways health and science communication, including related journals, have talked about and kind of addressed that issue too. So, as we're continuing to look forward in the class, after this week, we'll be talking about the campaign essay, where I'm asking you to look at an example of a health campaign. So we'll get into that and kind of work from there, but I did want to let you know that those grades have been updated. And again, thank you for your work. So that does it for us today. Thank you again to everybody who presented, and we'll hear from the next half of the health disparity presentations on Wednesday. So have a great rest of your day. Enjoy the overcast, rainy Oregon weather, and we'll reconvene again.